Good morning, everyone. Let me start by thanking all the organizing authority for this kind and very appreciated invitation. I would like to talk to you today about our recent study conducted with Dr. Fioravanti and evaluating the symptomatic effects of a cycle of sulfurous arsenical ferruginous mud bath therapy in patients affected by endostetritis. Endostetritis represents one of the most common osteoarthritis joint localizations, with an estimated age standardized prevalence much higher than those reported for knee and hip osteoarthritis. Endostetritis can determine an important clinical burden, inducing chronic pain and disability in routine daily activity. And as a consequence, endostetritis can negatively impact on quality of life. And what about balneotherapy and endostetritis? Unfortunately, while the effectiveness of balneotherapy in patients with knee osteoarthritis is corroborated by a number of systematic reviews, meta-analyses, clinical trials, the scientific evidence in this field is still scarce and unconclusive. However, in the last years, some randomized controlled trials were published, all showing positive effects of balneotherapy on end pain, function, and grip strength and quality of life. So, taking into account these considerations, we decided to retrospectively evaluate the medical charts of patients with endostetritis treated with a cycle of mud bath therapy. The present retrospective observational study included patients with bilateral primary endostetritis diagnosed according to the American College of Rheumatology criteria and treated with a cycle of mud bath therapy at Levico Terme Spa Center, located near Trento in the north of Italy, in the period from May to October 12-19. Further inclusion criteria were then represented by a symptom duration of at least 3 months and defined as global hand pain score superior to 30 mm on a 0-100 visual analog scale and a functional index for endostetritis score of at least 5. Then patients have had radiographic evidence of endostetritis within the previous 6 months and with a radiological score of at least 2 in at least 1 joint. Then patients had to continue to live at their homes located near the spa center. We excluded all patients with severe comorbidities of the heart, liver, and kidney, or with uncontrolled systemic blood disease or malignancy in the previous 5 years, or severe psychiatric illness or cognitive disorders in the previous 2 years, and pregnant women. Then patients affected by erosive osteoarthritis of the hand or with any other rheumatological or not rheumatological conditions which could interfere with breath and functionality were excluded. Finally, further exclusion criteria were represented by other treatments in the previous 6 months, as for example, another cycle of balneotherapy or intraarticular treatment with steroids or hyaluronic acid, or a new start or modification of therapy with symptomatic slow-acting drugs for osteoarthritis. The patients included in our study were treated with a combination of local mud baths applied on both ends for 15 minutes at an initial temperature of 46 degrees and immersion in a bath tube containing 115 liters of Levico's water diluted with tap water at 36 degrees for 15 minutes and for a total of 12 applications carried out over a period of 2 weeks. As you can see in the table, the mineral water of Levico is characterized by an elevated content of sulfate, arsenic, and iron. All patients continued their established pharmacological and non-pharmacological treatment for endosarcitis, as analgesics, NSAIDs, cytatoas, as defined before, or exercise, in addition to mud bath. Clinical assessments were performed at baseline before the start of the cycle of mud bath therapy and at the end of the cycle of the mud bath treatment. The primary outcomes of this study were patients' assessment of global spontaneous and pain on a 0-100 mm bath, with 0 representing the absence of pain and 100 the maximum imageable pain, and the functional index for endosarcitis score, which serves to quantify the functional disability due to endosarcitis. As a secondary outcomes, we assessed the duration of morning stiffness and grip strength measured by a standard dynamometer, health assessment questionnaire, short form health survey 12, and patients and physicians' global impressions of treatment efficacy and tolerability. As you can see in this flow chart, at Ladico Spa Center, from May 1219 to October 1219, a total of 324 patients with bilateral endosarcitis were treated with a cycle of mud bath therapy. According to our inclusion and exclusion criteria, we selected and analyzed the data of a total of 212 patients. And now we come to the results. As you can see in this slide, we observed a significant decrease of the global spontaneous and pain measured by VASP at the end of the cycle of mud bath therapy, compared to baseline and with a p-value less than 0.001. Similarly, the functional index for endosarcitis score significantly reduced at the end of the cycle of mud bath therapy, always compared to baseline and always with a p-value less than 0.001. And here are the results about our secondary outcomes. So all the secondary outcomes significantly improved at the end of the cycle of mud bath therapy with a p-value less than 0.001, except for the physical component score of SF12. The majority of the patients considered effective the cycle of mud bath therapy, reporting a marked or slight improvement, and similar was the impression of physicians. Also, the majority of the patients judged it as excellent or good the tolerability of the cycle of mud bath therapy. Indeed, only the 7% of patients reported some side effects, but these were transient and of so light intensity that no one interrupted the treatment. In conclusion, this preliminary retrospective study suggests the short-term effectiveness of mud bath therapy in controlling pain and improving functionality in patients affected by endosarcitis, and confirm the good tolerability profile of balneotherapy. However, a number of limitations needed to be considered, mainly related to the design of the study, which was an open-label and controlled trial, not blinded, not randomized, single center, and with no follow-up, all aspects which certainly could have limited the validity of our results. However, we can hypothesize that balneotherapy could have an important role as complementary and non-pharmacological treatment in the management of endosarcitis, especially considering that therapeutic options in these disorders are still very limited. Thank you for your attention.